Hello and welcome to our afternoon presentation. Today we're going to be talking about opioid use disorder and treatment options with Lynn Szabo. I know Lynn back from my days when we used to work together at Planned Parenthood, so I'm real happy she could be with us here today. She's a physician assistant. She got her degree from Duke University. She has worked for over 30 years as a physician assistant. That was hard to say. And she began in San Francisco at the first private practice to exclusively treat men with HIV. She's previously worked for Planned Parenthood, Open Door, Teen Clinic, Redwood Urgent Care in both Humboldt and Del Norte County. And she's currently working at the Open Door Teen Clinic here in Del Norte in Tuesday afternoons 1 to 5 and on Health Matters. You can find her on KFUG on Fridays, so tune in and check her out there as well. So I'm going to go ahead and welcome Lynn. Oh, hang on, let me unmute you. There we go. Hi, Lynn.
Hi, thanks for inviting me to speak. This is something that I've kind of been working with people that have this disorder for a long time, and some observations on what's available both here in Humboldt County. So can I get my slides up?
Oh, I just got a couple more housekeeping things and we'll come right back to you.
Okay. All right. Okay.
All right. So I just want to let people know that just a few housekeeping things. So if you have any questions at any time, you are muted, so you need to go ahead and put them in the chat box. Just a few group agreements. You know, we want you to be respectful. Respect and kindness are key. And if you're not, we can remove you. But that shouldn't be a problem because we haven't had any issues yet. And everybody who has been here has been wanting to be here to learn. Just know that everyone has a bit different background, cultural, racial, gender, sexually oriented. So please be aware of judgmental comments and always use positive language. And this is a safe space, free of judgment. It's okay to disagree with other people, but just don't put each other down for it. We want everyone to feel comfortable and make sure this is a safe learning space. If you're sharing stories, make sure that you are not sharing people's names. If it's not your story to share, you know, just say, I know someone who. We want to make sure that we're not spreading rumors or detracting from the point. And then always ask for questions if you don't understand. Don't be afraid to ask questions. We are here to answer those. And we know that this can be a sensitive topic. Sometimes it can bring stuff up for people. So we just wanted to let you know about some mental health lines, such as the mental health crisis line here. And then there's also a 24-hour crisis line. And again, just informed consent and privacy. Each person's participation is voluntary. Please respect the privacy of others and don't share their personal information. And this training is being recorded and live on social media. So that's one of the reasons we have it set up in this style, so that people, videos aren't out there on the internet for everyone to see who's participating. We want to make sure that we are acknowledging that we are on Indigenous lands right now, and that the work that we're doing is to benefit all, but it's also to better the lives of the Indigenous people on these lands. So there's many different Indigenous people who occupy these lands. The Tallawahd, Yurok, Karuk, Hupa, Wiyot, as well as many rancherias, Elk River, Resagini, Big Lagoon, Trinidad, Blue Lake, Table Bluff, and Bronerville reservations. We want to honor the Indigenous people who have lived here together and cared for this land and each other since time immemorial. We honor with gratitude the land itself and the people who have been the stewards of this land for generations. We know the effects of colonization have impacted Indigenous people disproportionately, and we hope that through this series we can learn together and help heal and work towards a healthy future. At the end, there will be an evaluation. So, you know, that evaluation helps us know how we're doing, and it also enters you in order to get raffle prizes and gifts. So make sure you do the evaluation for us at the end. All right, so I'll turn it over to Lynn now and share her slides. My share screen went away. There it went. Trying to manage on a laptop. All right.
All right, you're the one that's changing them, and I just give you the word.
Yeah.
Okay. So title slide, opioid use disorder, mostly talking about what it is, but also what we can do about it. Next slide. Okay. So the definition, and I think this is kind of an important place to start, usually definitions are, but the things we need to remember about this is that it's chronic. So it's not something like people just wake up one morning without it, but people definitely have a long journey toward recovery, and sometimes there's relapsing that happens, and that should be, people should be supported in being able to get around that, but also I don't think a relapse should be kind of looked at as a failure or a judgmental thing, but an opportunity to kind of refocus and move in a healthier direction. And it is an illness. But unfortunately, it's an illness that's associated with significant morbidity. So that means what morbidity means is that a lot of people have really detrimental effects on their health when they suffer from this disorder. And of course, unfortunately, we've seen across the nation increasing mortality. Next slide. So two types of treatment. There's medication-associated treatment, and then there's solely psychosocial intervention. And although there's these two areas, they're certainly not mutually exclusive from each other, and there can be overlap. And some people prefer to have their recovery be unassisted by medication, and then I think that's okay, but that's not really the only path that people could take. And especially in Del Norte County, psychosocial interventions can sometimes be kind of scarce. So next slide. So medication-associated treatment. So this basically includes two medications, methadone and buprenorphine, which is also known as Suboxone. Suboxone is the brand name. Buprenorphine is the, I guess you could call it generic name. Well, I've heard it on the street as Bupers. Next slide. So the thing with methadone is that it's a long-acting opioid agonist. And what an agonist is the chemical, the way it affects the brain is that it kind of plugs into the receptor that an opioid would be in, and it kind of makes it like no room for the opioid to land, okay? Methadone binds to the opioid receptor, just like I said, and then it produces a biologic response. So when it hits the brain, then the brain responds in a certain way. Methadone decreases cravings, that's the response, but it also decreases the euphoric effects of opioids. So hopefully that means that somebody's not really gonna be physiologically needing it, but also they might not be getting a psychological effect that could be important to them. It is fairly effective, and it's especially good for pregnant or nursing women, but something that we have to remember is that the infant will still withdraw from opioid use. Okay, that's important to remember. The bad thing about it is that it's got a really, really long half-life, and sometimes if their dosing isn't completely correct, they can try and take more to try and get those euphoric effects, and then all of a sudden they're in overdose land. So they're not really getting the effect that they would usually get, and then all of a sudden they're in a trouble spot. And I have seen people overdose on it, not uncommonly, unfortunately.
Is that why a lot of methadone clinics, or when you prescribe methadone, it's a daily dose and they have to do it under supervision?
Right, right. Because they don't want people taking home a bottle of pills taking a pill, not feeling like they expected to feel at a certain time period, and then taking another one, until you all of a sudden have kind of this traffic jam of opioids hitting the brain and decreasing the respiration response. So, next slide. So again, some other methadone drawbacks, it can cause cardiac arrhythmias, so it can affect the way the heart beats, and sometimes the heart's not beating in a way that can keep blood flowing through the body. It can affect the way people breathe, and sometimes people kind of lose their respiratory drive, and if they stop breathing, that of course is associated with high mortality. And this is the one we didn't really talk about as healthcare providers very much, but methadone especially can make people that use it, flip back to last slide, can make people that use it have a kind of an unusually sensitive response to pain. And I know I've seen, people who are maybe opioid dependent or who have used methadone medically for chronic pain syndromes, and they'll present with really dramatic responses to pain, and sometimes in the ear that gets them not treated very well, but they're actually responding in a way that their brain is telling them to. It's not overly dramatized. It's really that, and this is unfortunate because this oversensitivity to pain is lifelong. Excuse me. Next slide. So buprenorphine overview. So this is a partial mu opioid agonist. So what that means is the mu receptors in the brain are the receptors that these, excuse me, these drugs are kind of plugging into in the brain. And it binds at the same receptor sites as methadone. Okay, so we're kind of in the same part of the brain, very similar physiologic responses. But buprenorphine, in compared to other opioids, doesn't really produce a strong response. It kind of puts the brain in neutral a little bit, so people don't feel that euphoric buzz, and that can be helpful for some people's recovery. But some people don't like that, and so they can get a hold of buprenorphine and kind of and use it in an unhealthy way, crush it up, and then inject it, so they get a higher high. Excuse me. Next slide. So to get around this, buprenorphine is oftentimes mixed with naloxone, and it's taken transbucally. So that's kind of a way to get around the crushing and injecting behavior that some people use buprenorphine for. Buprenorphine less likely to cause death when mixed with other medications like benzos or alcohol, especially if people are trying to get their brain into a certain space that they associate with being high. So next slide.
Can you say what transbucally means?
Okay, transbucally means that it's a little film that they put on in the mouth, kind of up against the cheek. And the reason they do that is because, well, one is you can't crush it up really, it's like a film. But the other thing is it has really kind of immediate penetration into the bloodstream. And it's also kind of a helpful way to get both the naloxone in with the buprenorphine. And this I found out when I was just looking at naloxone. I should say as an aside, all this information comes from a medical journal called Up to Date that a lot of medical people use. And I just, printed up and went through articles. So that's my data source. And that, I think in these days of respecting science, that's an important aside. But another fun fact is long-acting naloxone can be used as an antabuse medication for opiate addicts. So we're familiar with, people who have problems with alcohol and commit every day to sobriety by taking an antabuse pill. You can kind of do the same thing, although I don't think it's really available around here. I've never even heard of it until I was researching this talk. So
I've heard of it, but I haven't heard of it being used. Yeah.
Right. Yeah, it's unfortunate because I think the whole the whole solution to dealing with opioid use disorder is maximizing resources. And it's unfortunate, I don't think that we have this available up here. Next slide. So psychosocial treatment, there's a couple of different things. Contingency management. This rewards positive behavior with prizes and privileges. And I think probably people that go into, and correct me if I'm wrong, Jermaine, but people who go into like programs where they're not really inpatients like in a hospital, but they might be in a group home. Maybe they got a nudge from the judge. And they go on a blackout period initially, and then they have to have certain behaviors that reward, that they get rewarded for, like maybe being able to talk to friends and family over the phone, or you know, being able to have supervised outings and things like that. So this definitely helps people, but only in the short term. So the studies that looked at whether this was you know, something that could be used long term, it really people are only doing it because they're kind of in a program that's structured and they're kind of forced into it. But it doesn't really give any insight into why somebody might have an opioid use disorder, or it doesn't really give long-term solutions to staying in recovery. So I don't know of anybody who does it up here. I guess, and the only example I can think of would be in Eureka, like some of the the group homes where, you know, clean and sober homes where people go through blackout periods and then slowly have to, through their behavior, get rewards back.
I think waterfront recovery is probably the only most local, and that's in Humboldt County. We don't have any live-in recovery, and most people go to the Bay Area from here, especially because that's what their insurance will cover.
Right. So do people just singing trees?
I think Singing Trees is private and not insurance based.
Okay.
And I know for like UIHS, the closest one for the insurance with UIHS is through isn't in the Bay Area.
Okay, sounds like Crossroads isn't an option in Humboldt anymore then.
Yeah, I'm not sure. I think Crossroads is more of a sober living house, so you have to have already been. It's not like I'm kicking it. I've already kicked it. And I need transition.
So you
if somebody else knows, feel free to chat us up.
Yeah, C Street Detox maybe initially, and then I don't know. A lot of it depends probably what's available, where the available beds are day to day. I don't think they put a lot of thought into matching the right person with the right program. To be honest. Yeah,
and I know there's a new program opening up in McKinleyville but it's more kind of transitional housing type stuff. That's AJ's Living in McKinleyville, but.
Okay.
So it is one of the things we really lack here is live-in recovery. And something that came up in our last panel too is it doesn't really involve the family. So the family doesn't know how to deal with people when they come back to the home either, and like how you support people. So this can work for people, but it's very complicated.
Yeah, and not easily accessible, I imagine, because it's not always, the bed's not always available when the will to access care is there. And I remember from the Jordan Recovery Center, which was up here for a while, that when I was working in the walk-in clinic for Sutter, is that oftentimes they would bring a lot of people in who were especially interested in getting tramadol, which used to be called Ultram. And I should just throw that out there as another interesting fact. That's an opioid. It was initially marketed as a non-opioid control for pain, but it's definitely an opioid. And I think that's why people in these type of recoveries that used to be in our community would come looking for it. So.
Yeah, there's actually been changes in the vet industry because tramadol is something they use a lot for pets, and people were seeking opioids through pet injuries. So tramadol is something that has been on the market through pet.
Yeah, totally.
Yeah,
but oftentimes people will come in and they'll be mad because it's been marketed as a non-opioid, but it really is the same receptors, and it is classified as an opioid by the government if that's, you know, more meaningful to some people than others. Oh. Anyway, next slide. Motivational interviewing. maybe you can give an example of something that's available here for this. Maybe associated with the Suboxone program that Katrina Groves was doing, and now I think they have somebody else doing it at Del Norte Community Health Center. But this actually has some data to support its use. So you're having the individual look at the reasons they use drugs. You're looking at for triggers and situations that might motivate somebody to be in kind of a drug use kind of mentality, and you give them skills to get out of it. So it kind of helps with problem solving, and it's more recovery focused in its kind of activities. But I think we could use some of this up here. Just not only giving people something else to do, but also more deeply being able to look into what's fueling their addiction. Because I'll tell you, as a provider, like in the ER or maybe in a walk-in clinic or urgent care, or even family practice, when providers are caring for people that have chronic pain issues, it almost feels like the pain is in the soul sometimes. And that the back pain is a proxy, the abdominal pain is a proxy. And it's like unless you really recognize what's motivating the desire to reach out and see opioids as a solution for a lot of the problems that somebody has in life, I don't think they can ever really get out of that mindset. And I think that's too bad, because when I work with a person with chronic pain, for example, and when I was in family practice, I talk about having a chronic pain toolkit. And I go into the idea, like, if you're going to build a house, you're going to need a lot of tools. So if you have a hammer, that's a really important tool, but it's meaningless if you don't have nails, if you don't have lumber, if you don't have concrete, if you don't have land, all the other things all the other resources you need to put together to help kind of solve this problem. And so that's kind of the problem that we see as providers when and the reason I bring this up actually is because I think a lot of providers have contributed to people's opioid use disorder, maybe because they had dental problems and they didn't get meaningful help. All they got was Vicodin, or they had some other problem and they got put on methadone, and then all of a sudden it got taken away from them, and then they kind of moved into dysfunctional ways to take care of it. So. But it feels sometimes like we're trying to treat something that's not really best treated with opioids, that really needs to be treated on a whole different level. And I think motivational interviewing might help uncover that a little bit, to try and see what motivation is not really the right word, but what drives somebody to make a choice that might not be a really constructive choice for them in their lives. So I'd like to see more of this up here, although I assume that they have it with the Suboxone.
Yeah, and a lot of the substance use disorder, they use what's called cognitive behavioral therapy, which is very similar. To really get to some of those source and really change and look at your behavior and change that behavior, and make, like, being aware in that moment of choices, and also what's underlying those choices, right? Like,
right.
It may have started with pain, and we know that opioid use increases your pain and decreases your tolerance, right? So then now how do we make choices to use alternatives to address the pain, but also the other causes?
And then I think that providers also have to be able to have more time to be able to talk to people and to try and see more where they're coming from, and giving them more of a voice. And not only guiding what the provider is able to do for somebody, but what the patient's able to do for themselves, and so that they can work together better. But anyway, I don't see that it happens much up here. We have 7.5 minutes to talk to a patient. And that doesn't really identify triggers much, or give people, positive ways to focus on getting better. So next slide. 12-step programs, actually my favorite. Works well for a lot of people. there is a kind of a resistance to them sometimes because they can be seen as being a little bit too religious in orientation, but I don't think that that's like 100% required. I think people can modify it for their own internal beliefs. But weirdly, according to up to date, there's not really very many studies to looking at 12-step programs. I find that almost impossible to believe. So what I think these are, 12-step programs are really rules for living right. And I'll ask almost anybody that I'm seeing that has a recovery process going on, I'll ask them what step they're on. And almost all of them that are using 12 steps know exactly where they are. And actually I had one patient who was kind of exceptionally using 12 steps to really, really help him. And he always said, well, I'm on the first step. I'm always on the first step. I'm always going to be on the first step. And what he was telling me was he's an addict and he's going to, commit his recovery to a higher power. So I thought that it was incredibly powerful. And then when I get in the room and if I ask somebody what step you're on and they say, well, I'm not really doing this, for this reason, that reason. And then it's almost a marker for me that they're probably going to relapse. So I think a lot of people in recovery really need the structure. And I wish it wasn't so stigmatized, because I think it can be used for a lot of other problems that people have in life unrelated to opioids, problems maybe in their family or problems with their own personal stuff. And I think it's really powerful. I'm shocked that my source said there were not very many studies. I would really dispute that. But the people that I've seen are successful. I think they're successful because they deal well with 12-step programs. And there's tons of them here. Probably a lot online too now that, you can't really go into a meeting type situation.
Yeah, there's a lot of its success, especially with opioids, with the combination of medicated assisted treatment and 12-step together. Although some 12-step programs won't let people who are on medicated assisted treatment into their program because they don't believe that they're abstaining. So
right.
It's up to each 12-step leader to decide.
Yeah, that speaks to, if you can't find a program specifically, a specific group of people that can work with you in the way that you can work, then you could start your own group. Because it's one thing that's interesting is there's not much 12 steps for nicotine. There's Nicotine Anonymous, but I've never really seen it be a force in any of the communities I've worked at. So if somebody is saying, that you can't do another substance in order to ensure your recovery, I would ask why nicotine's tolerated then, because I think that's a discongruity. But, I don't know. I'm willing to be educated on that point. So, I think that with the advent of online stuff and Zoom meetings and stuff, although for some people it's not going to be optimal if they don't have the technology, I still think that there's a group out there for somebody who has, a particular need or a particular worldview or a particular way they want their recovery to go. So,
yeah, I think the lesson there is give it a try and keep trying and find the one that fits. There's many out there.
Yeah, absolutely. So my last slide here, coming up to the end of my organized remarks, is, so Del Norte, we've talked about, it has medication associated treatment at Del Norte Community Health Center. So this would be buprenorphine, and we have 12 steps, but what else do we want?
Yeah, and UIHS also has medicated assisted treatment.
Oh, good. Thanks for putting that in. Awesome. But, I would think that when we get out, one thing we're going to learn from COVID-19 is that, I think we're going to have, as individual patients or as individuals facing particular health challenges, we should be asking our medical community and I'm not just talking about doctors or clinics, but other healers in the community, what works best for us. And I think we should expect a thoughtful response from them. And my hope is that there's my dream is there's going to be money to put together programs that can help people make meaningful changes, because it's really kind of impossible to do it alone. And there are some resources and there's some good data that guide us to make choices that work. And we know that has to be an ongoing thing because it's a lifelong struggle for people. So hopefully we could be less judgy and more supportive.
Yes.
Hopefully. Absolutely. Yeah.
Let's hope for that. So let's just talk a little bit about, like, what has your experience been like here in Del Norte County? And you talked a little bit about what you would like to see, but what are some barriers that you've seen with people who are trying to get on that road to recovery?
Oh, I think a big barrier is there's not enough resources to meet the demand. That's kind of defines medicine in the United States for sure. Insurance companies are barriers. I think limited resources are barriers. There's geographic barriers because, somebody who's in the midst of withdrawal is probably not going to hop into their car and drive down to Eureka to access a program there. And it might even be hard to get like a family member or a friend to drive them down. And certain times of the year you can't because, roads are closed and things. So all of those have been a problem. So I think we should have stuff that's more locally available, definitely. And more beds, I guess, is the easiest way to say about that. I think there's also, it's a little bit less than Humboldt, but it's still there. But I think Del Norte has kind of a really conservative part to it that that sees these kind of recovery issues as a moral defect in somebody. And I think some people in the medical community share that. There's certainly a lot of providers who didn't want to practice here because they just felt like it was a big drug seeking community. Mm-hmm. And I actually, in my career, I think I successfully looked beyond it. I think it's a community that has unique challenges. I think there's certainly a lot of problems here. I think that makes it like one of the best places to make a difference as a medical provider, but we can't really do it as individual medical providers if we don't have the resources or the insurance backup to get what we need.
That makes sense. Yeah.
Yeah.
All right. Well, what about the other side? What are some successes or some hope that you've seen? I know that's the harder question.
Yeah, that's a harder question. In the time of COVID, it's also overwhelming. It's like we're trying to fix that problem first.
Right.
Yeah, I think there's some successes because Del Norte is kind of a small, tight-knit community in some ways. I think that if somebody, as a healthcare provider, somebody comes here and pays attention, there's like amazing things here. And so I have seen some successes that I wouldn't have predicted happening. And I think you have to have an open heart maybe and not be so judgy on people. But I've, sometimes you have to kind of risk manage a little bit, like, encourage people to take baby steps and not expect something that's completely overwhelming for them to do. So some successes I've measured, in smaller, like less grand changes in somebody's life. But for example, one patient I remember in particular who did not have opioid use disorder, but had an alcohol use disorder. And he was homeless for a long time, and he did end up dying of his disease, but he died housed. And I thought that was a big success. I see successes happening in Humboldt County when I look at Arcata House and the night shelter and the people who run that. Hatcher's another success that somebody might not fully embrace because they're judgy and punitive, and really, for somebody in a really disorganized, maybe drug-addled state who makes some good decisions, I think you should get a standing O for that, I'd really like to see is some kind of recovery systems that are kind of walk-in on the medical front, instead of, because I think this is something that Del Norte doesn't do very well, like have a specific time 3 weeks from now that you're going to show up at this certain place and have, you know, a certain amount of time with a provider, because I think we're more in the moment. And I don't think the community as a whole does really well when you know, time restrictions are put on them that are not as meaningful. So I'd like to see something that's just walk-in. So when somebody has an opening in their heart, then they have an opening in their schedule, you know, and for somebody's schedule to be available to help them and not make it barrier. So that's my biggest thing.
Yeah, I agree. When people are ready for change, you have to jump on it and you have to be there because that's that moment, right? And you can't tell them, all right, you can change in 3 weeks, right? You can make it till then, because they're just going to try and survive till then, and it may not be the best for them.
Right, exactly. You know, and especially, I just don't know how to, you know, this kind of goes to a study. This is a little bit off topic, but this is a study that I read a long time ago about people who no-showed clinic appointments. And when they no-showed, that their clinic was associated with a resident teaching program, I think in Oklahoma, they would send the doctor that was supposed to see the patient to the patient's home. And they would kind of make an inventory of things that might be keeping that person from being able to get to a clinic appointment at time. And what they found in the study is not everybody is grounded in time, like healthcare providers are. I know, big shock, you know. So, you know, and not everybody has a functional car, and not everybody has a calendar, not everybody has an iPhone, not everybody even has a phone, not everybody, you know, like if it's raining, you can't walk there, you know, stuff like that. So I think the door should be open when the heart is ready. So
yeah, part of that open door policy, right?
Right, but they're not seeing that so much.
Yeah.
So yeah, most providers are really resistant to that, which I think is kind of sad.
I think maybe there might be a fear of like, I don't know what's going to walk in the door, or also, what if I'm just sitting here and no one ever comes?
Yeah, like we've kind of lived through that, but I think there's provider anticipatory hysteria, which is really judgy, and you know, I know this person, I know what they're going to do. They're going to come 1 minute to 5, and they're going to, you know, have 800 things for me to do, and I really have to get home because my kids, you know, nobody's going to be taking care of them, and stuff like that. But most of the time that doesn't happen. So the provider's sense of that it's always the worst case scenario, that there's really no follow through. So I'd like to see providers let go of their anticipatory hysteria, and it's much easier to be a healthcare provider. It's much more enjoyable when you aren't thinking in worst case scenarios constantly. Not only does it give patients the choice, but it really, really lowers the stress level. So you can sit back and talk to people and listen to them.
Yeah, I think we all need to practice that.
Oh, completely, especially on time of COVID, because we're all like halfway, you know, like losing anyway. But so anything else?
Did you have any more slides? You just had this last one, I think, right?
Yeah, the last one that I put out there to the people listening. What else should we have here? I don't know.
Wendy Wrinkle with UHS, she said, yes, more local resources. She agreed with you on that one.
Yay, thank you. So, yeah, that would be nice. It'd be nice if United Indian Health had an acute care function here. Well, a girl can dream.
You might have a PA available for that.
Yeah, totally, absolutely, ready to go. So,
yeah.
But anyway, yeah, I think that's the way medicine actually had to be. You know, for Open Door, maybe about 20 years ago, they tried to do that, and the providers like lost their minds, because they were just going to take the plan was for Eureka Community Health Centers to have 100% dedication to anybody who walked in that day that they would be seen, and the providers just couldn't couldn't go there.
It's a lot, and you have to continually do it to really get that bottleneck from overwhelming people.
Yeah.
I remember when we switched over to that with Planned Parenthood in our mobile clinics, and it was overwhelming at first, but then it started to really like even itself out because people understood and like how it happened. So yeah,
right. You get this initial tsunami, and then it goes into equilibrium, and it works really well for people, and the providers end up liking it. But there's just this time of fear that people can't get beyond, I think.
Yeah. And then, you know, it's hard to manage and you don't know what your billing's going to be like.
But you know,
there's ways around it. And you know, you can see both sides. And I've worked in clinics. I worked with you. So I can understand some of the barriers that can be there.
Right. So, fewer meetings, more patients. That's what I say. But
yeah, right. And you've always been a very patient-centric provider, and I've always appreciated that about you.
Yeah, I'm not very good at process though, so I'm a journey too. So
yes. Well, that's why you have a team, right?
Yeah, that's why I have people that point me in the right direction for sure.
Yeah,
absolutely.
So, were there any questions out there? We want to open it up and let people ask questions about opioids, treatment options in general. Lynn is a plethora of information. And there is a slight delay between online and us live, about 45 seconds, so we can fill some time. But what makes you passionate about this, Lynn? Why?
Passionate about it?
Yeah, why did you want to talk about this today, besides me asking you? But
well, oh wow, there's a lot of things. I think a lot of these kind of topics are getting lost in COVID right now because of COVID's so in your face and demanding. But I also know that for 24 years, you know, of my work in this community that we've never really had much to offer people. And I know it's a huge problem. And I know people that have, you know, died accidentally, and it happens commonly, even more so now that we recognize it. But I also know people that took their lives intentionally because they felt like they were lost and trapped. And I really want to, you know, carry the fight onward for those people, because that shouldn't have happened. That shouldn't have happened. They should have had somebody who could have helped them. And so I like this community. Like I said before, there's no better place to make a difference. Even if you're bandaging a boo-boo, you know, and oftentimes there's more resources than somebody might have. So especially if they live behind Safeway and they're kind of disorganized. So,
yeah.
You know, you can do a really tiny kindness that makes a big deal for somebody, and you never know who you're going to help. So, anyway, blah blah.
What's your advice for other providers to get them to feel a little, to educate themselves, or to want to be maybe X-waivered so we could have more MAP programs and things like that?
I think providers really have to own when they put up barriers, and I especially this anticipatory hysteria is a huge one. I mean, it's in the clinics daily. It took me a long time to get to the point where I wasn't trying to micromanage everything, where I could put trust in the people around me and not see every outcome as being, you know, like defined ahead of time as a disaster. So weirdly, sometimes I go back into whatever employee lounge is, and I just wash dishes because I take what I'm really doing is taking myself out of the action, letting the people who are so great at doing their jobs do their jobs, and then eventually they'll come and get me. And you know, and by then I'm like emotionally not as like amped up about it. I don't know, that sounds really trite, but I don't mean it to. If providers could calm down, a lot more could be accomplished. If providers didn't micromanage, a lot more could be accomplished. So
I think that's true of anyone who is in that kind of place of management too. Like,
I know it can
let
definitely
people
want
do
people
what they
that can
do.
earn that level. Yeah,
All right,
it's
oh, go
yeah.
ahead.
Oh, it's so much easier when you don't have to stress about whether your medical assistant's doing the right thing. 'Cause they always are. They don't they don't need you to like sort it out, except maybe in a code or something. And Lord knows we don't have many of those. So
All right, we had a question in the chat. They're wondering, are you familiar with peer community health workers? I think there are some at Open Door. And what
I I
the
think
best
yeah,
spaces for this?
that's kind of been around a lot. I think it's had other names too, but I think it the first time I was aware of it was reading about the Haight-Ashbury Free Clinic, where they took people who were in recovery and they put them out there as um, resources for people newly in recovery. And a lot of the time I'm familiar with it is, you know, like on the C Street Detox, I think is the people that are sitting there kind of managing the house, I think have probably gone through their own recovery struggles. I think that it's sometimes doesn't work very well, but a lot of times works well. You kind of have to have the right person and they have to be in the right, you know, point in their process so that they can be the best help for somebody who's definitely struggling.
What kind of, do you have any advice for like what kind of training or where peer community health advisors would be best served or where they would best serve people? Like what kind of locations or what kind of trainings they might need? And this isn't your area of expertise, so just
Yeah, go with it. What I'm interpreting this question as, and I might be wrong, is somebody who has already gone through their own recovery struggles and is solid in their recovery and can be kind of a hand up for somebody who's struggling. And so to me, the best school is like the school of life, but I don't know that there's any more education that somebody needs for it, or is there a certification or something like that? I'm not familiar with it. Sometimes I think it doesn't work so well, actually, because you can pull, when you're trying to help pull people up, they can pull you down sometimes. So I think it's, you know, it's kind of fallen out of favor. It might be swinging back around. Remember, I've been in medicine for 32 years, so everything that's old is new again.
yeah.
But that's about all I know about it.
Yeah, so kind of just bouncing off what you were saying, like if peer community workers are out there somewhere, really making sure that they understand things like healthy boundaries and their own triggers, and probably
Right.
lots of self-care and things like that, so they don't end up being pulled back down, right? Because I've seen this a lot in social work and just help work in general too, is most people who go into help work are because they have life experience and they want to help somebody else. And so you're dealing with your current traumas as well as somebody else's current traumas. So it's about how to separate out your traumas and not take on somebody else's too.
Yeah, absolutely.
Yeah, great
In a
question.
small town, I imagine that'd be hard to do.
Yeah, we have a really high across the board trauma rate for a lot of different things, which is why we have all those lovely statistics about all the side effects of trauma.
Yeah, that's some ways what makes us unique, but hopefully it also makes it a good place to make a difference.
Right. And you know that you have a shared experience with a lot of people in your community too.
Absolutely. Yeah.
Okay. We'll just give it another minute, see if there's anything online. Not seeing anything on Facebook. So, well, we're getting close to 4 o'clock, so we can, do you have any last thoughts or anything that you want to make sure that people are walking away with or how they might be able to make a difference themselves?
12 steps. Always know where you are on your steps, because you don't know where you are until you know where you are, you know? So,
I like that. That needs to be a t-shirt, Lynn. You don't know where
yeah,
you are until you know where you are.
exactly. All right.
Okay, thank you so much. It was great to see you, and thanks again for being a part. And we look forward to seeing you out in the community, and go check out Lynn at Teen Clinic at Open Door on
Yeah,
Tuesdays, and listen to her on KFUG at Health Matters every Friday.
Friday at noon. Okay.
Friday at noon. All
I'm
right.
about hepatitis C tomorrow, so yay.
Oh,
Something
yeah.
different
And
from
I think
COVID.
that's an important one too, because a lot of injection drug use is a high risk for Hep C.
Absolutely. Yeah.
Yes.
And it's a chronic, potentially lethal virus that we've had more success with than our current viral problem. So yay, a little bit of positive news. Okay.
Yeah, one virus we can help come
Yeah.
back. All right. Thanks again, Lynn. Always good to see you. And everyone, thanks for joining us. Make sure to fill out the evaluation. I will put let me share the link here. So right here, just make sure that you are filling that out for us. And I put it in the chat, and it's right there on the screen for people. And make sure, Lynn, you're our last one of the week, so thank you. We had a really great first week, but we want to have people join us again next week. So stay in touch with us via Facebook, website, and make sure that you register at Eventbrite so you can get some swag. We're going to have t-shirts and stickers and all sorts of cool stuff out there too. We want to make sure people get all the goods. And we also got, do you need any of these, Lynn? We got some really cool RX Safe Del Norte face masks.
Yeah. Yeah, those are big. Yeah, you have
So,
quite a success with your efforts.
yeah,
in
so
both
let me know if you need some face masks at Teen Clinic, I can drop some off for you.
Yeah, do. Yeah,
Okay.
please. Okay.
All right. Thank you again, and have a great day, everybody.